One of the tools that we use for diagnosing an arthritic joint is an X-ray. I'd like to describe an X-ray of an arthritic hip and a normal hip in the same patient. If we first look at the right hip, which doesn't hurt, we can observe there's a distinct space which separates the ball from the acetabulum or socket. The space is maintained by cartilage, and it's the cartilage that removes the friction and distributes the stresses. If the cartilage wears down for whatever reason, the bones begin to rub and the bone reacts in a dynamic fashion. We can understand that, and that helps us understand how long the process has been going on and how advanced the process is. If we now view the left hip in great contrast, we can see the space which existed on the right side has completely worn away. Notice the bones are touching. We call this bone on bone. So the forces are being concentrated in the bone, and the bone is reacting to those stresses by trying to get denser and stronger to meet that load, and we can read that by seeing the bone appears white. We call that sclerosis. If you look here, we can see there's some bony projections off the edges of the femoral head, both at the top and along the side. Those are bone spurs or osteophytes. That's a physiologic attempt on the part of the body to distribute these stresses. Normally there's fluid within the joint, and the fluid nurtures the cartilage. Fluid always takes the path of least resistance. The cartilage fissures, it breaks down, the fluid gets pushed into the bone and creates bone cysts. We observe there's black spots both above and below this area of contact, and those would represent bone cysts. This is one more finding in a late degenerative osteoarthritis. This gentleman was remarkably disabled from his arthritic left hip. Unfortunately, he did not respond to therapy and anti-inflammatory medicines, and he reached a point where surgery was indicated, and this is an image of his total hip replacement. We can see the new cup and stem placed down his femur, both made out of titanium. The hope is that bone will incorporate into and onto these components to stabilize. We can see an artificial ball, now made out of a ceramic, and a plastic liner, in essence acting like the cartilage. A huge part of creating a successful result is preoperative planning. And now, using sophisticated software with digital imaging, I can plan that much more carefully. This software allows me to plan very closely the exact size acetabular shell which I'll place and the appropriate position for that shell. Observe this large black opening. That's a large degenerative cyst, which at time of surgery I'll clean out or debride and place bone from the preparations into the cyst as a bone graft, and that can regenerate new bone and heal. We're also now going to plan the size of the femoral component, and this is a template for surgery. It allows surgery to go much smoother and for the outcome to be much more predictable. We've chosen a size femoral stem. We've chosen an approximate size acetabulum. We can fine-tune exactly where we want to place it, the height of the stem to be placed, so we can predict the exact level to remove the upper part of the femur. This image shows the painful hip before the surgery with bone on bone and a large degenerative cyst. The preoperative plan for size cup to be placed, the style stem to be placed, and the appropriate levels. This is the postoperative film. It's a non-cemented cup. It's a non-cemented titanium stem. Notice how close the component positioning is to the preoperative plan. Observe that dark hole or bone cyst that we saw preoperatively, now bone grafted.